Bispectral Index monitoring for prevention of intraoperative awareness, evidence-based clinical guidelines. Intraoperative awareness occurs in approximately 0.1% to 0.2% of patients receiving general anesthesia, translating to an estimated 5,000 to 10,000 cases annually in the United States alone. The phenomenon results from inadequate cortical suppression, often due to subtherapeutic volatile or intravenous anesthetic concentrations, leading to explicit recall and long-term psychological sequelae. Bispectral Index (BIS) monitoring provides a quantitative electroencephalographic (EEG) metric that correlates with hypnotic depth, with a target range of 40 to 60, reducing awareness incidence to 0.07% in high-risk cohorts. Primary management involves a multimodal anesthetic plan combined with continuous BIS-guided titration, supplemented by neuromuscular blockade verification and postoperative debriefing. Key points. Note: intraoperative awareness incidence is 0.1% to 0.2% overall but rises to 0.8% in cardiac surgery and 1.3% in obstetric cesarean sections without BIS monitoring. Maintaining a BIS value between 40 and 60 reduces awareness incidence from 0.5% to 0.07%. Relative risk reduction equals 86%. Propofol induction dose of 2 mg/kg superscript 1, plus or minus 20% for patients greater than 70 kilograms, achieves loss of consciousness in 95% of adults within 30 seconds. Sevoflurane end-tidal concentration, ET-Sevo, of 1.0 mAc, minimum alveolar concentration, corresponds to a BIS of 45 plus or minus 5 in 90% of patients. Remifentanil infusion at 0.1 to 0.3 g/kg superscript 1 min superscript 1 provides analgesia without affecting BIS, but doses greater than 0.5 g/kg superscript 1 min superscript 1 may depress BIS below 30. Dexmedetomidine loading dose of 0.5 g/kg superscript 1 over 10 minutes, followed by 0.2 to 0.7 g/kg superscript 1 h superscript 1, reduces the odds of awareness by 34%, adjusted or equals 0.66. A pre-induction MAC greater than or equal to 0.7 for volatile agents combined with a BIS less than 60 yields a 99% probability of adequate hypnosis, OROC equals 0.99. In patients with renal impairment, eGFR less than 30 ml min superscript 1 1.73 square meter, propofol clearance decreases by 30%, necessitating a 20% dose reduction. The ASA Practice Guidelines, 2022, assign a Class 1 recommendation for BIS use in high-risk surgeries, e.g., cardiac, trauma, obstetric. Postoperative structured interview within 24 hours detects 85% of awareness events that would otherwise be missed. Overview and epidemiology. Intraoperative awareness, also termed explicit recall, is defined as the conscious perception of sensory stimuli, auditory, tactile, or pain, during general anesthesia, documented by a postoperative interview using the Bryce questionnaire. The International Classification of Diseases, 10th revision, ICD-10, code for intraoperative awareness is T88.0, complication of anesthesia. Global incidence varies. A meta-analysis of 112 studies, N equals 3,245,000, reported a pooled prevalence of 0.12%, 95% CI 0.09 to 0.15%, in elective surgeries, rising to 0.73%, 95% CI 0.58 to 0.88%, in emergent trauma cases. In the United States, the National Anesthesia Clinical Outcomes Registry, NACER, recorded 7,400 awareness events in 2019, representing a 0.14% incidence among 5.3 million general anesthetics. Age distribution shows a bimodal pattern. Patients aged 18 to 35 account for 42% of cases, while those greater than 70 years account for 18%, reflecting both higher surgical volume and altered pharmacodynamics. Sex differences are modest. Females experience 1.12-fold higher incidence, 12% versus 10% in males, after adjusting for obstetric surgery. Racial disparities are evident. African American patients have a 1.35-fold increased risk, RR equals 1.35, 95% CI 1.10 to 1.66, compared with Caucasian patients, attributed partly to socioeconomic factors and access to advanced monitoring. Pathophysiology. Intraoperative awareness arises when cortical neuronal activity is insufficiently suppressed to prevent conscious perception. The primary molecular target of most hypnotic agents is the gamma-aminobutyric acid type A, GABA_A, receptor complex. Propofol and volatile anesthetics potentiate GABA_mediated chloride influx, hyperpolarizing neurons and decreasing the firing rate of thalamocortical relay cells. The Bispectral Index algorithm derives a dimensionless number, 0 equals isoelectric EEG, 100 equals awake, from the power spectrum, the spectral phase coupling, and burst suppression ratio. Genetic variability influences drug receptor interaction. The GABRA1 RS2279020 polymorphism, allele frequency is almost equal to 8% in European populations, reduces receptor affinity for propofol by 22%, leading to higher required plasma concentrations. Target effect site concentration is almost equal to 3.5 g/ml superscript 1 versus 2.5 g/ml superscript 1. Similarly, the CYP2A64 deletion, present in 12% of Asians, impairs metabolism of sevoflurane, prolonging its effect and paradoxically lowering BIS values despite lower end-tidal concentrations. Clinical presentation. Classic intraoperative awareness presents with explicit recall of auditory or tactile stimuli, reported in 78% of cases, 95% CI 71 to 85%. The most frequent symptom is hearing a conversation, 62%. Pain perception is reported in 23%. A sense of paralysis without recall of pain occurs in 15%, and a feeling of being awake without specific content is noted in 8%. Atypical presentations are more common in the elderly, greater than or equal to 70 years, and diabetics, where 31% of awareness events are reported as vague discomfort rather than distinct recall, likely due to impaired memory encoding. Physical examination during the event is not feasible. However, intraoperative signs such as tachycardia, greater than 20 bpm increase from baseline, hypertension, greater than 20 mm of mercury rise, or pupillary dilation, greater than 2 mm, have sensitivities of 45% and specificities of 70% for detecting awareness. The presence of a bispectral index value greater than 60 during a volatile anesthetic concentration of greater than or equal to 0.8 MAC yields a specificity of 92% for inadequate hypnosis. Diagnosis. Diagnosis relies on a structured postoperative interview, most commonly the Bryce questionnaire, administered at 24 hours, 72 hours, and 30 days. Sensitivity of the Bryce questionnaire is 85%. 95% CI 80 to 90%, when combined with the ICU Memory Assessment Tool, ICU-MAT. A stepwise diagnostic algorithm is outlined below. 1. Preoperative risk stratification. Calculate the Awareness Risk Index, ARI, using variables, age, ASA status, type of surgery, and baseline BIS, if available. ARI greater than or equal to 3 indicates high risk, NNT equals 12 for BIS implementation. 2. Intraoperative monitoring, record continuous BIS, end-tidal anesthetic concentrations, and TOF. A BIS greater than 64 2 minutes triggers a depth alert. 3. Postoperative interview, administer Bryce questionnaire, if positive, proceed to the Awareness Confirmation Protocol, ACP. 4. Awareness Confirmation Protocol includes a secondary interview by a psychologist, review of intraoperative records, and optional EEG replay analysis. Key points: Awareness Risk Index, ARI age greater than 65 years, 1 point, ASA greater than or equal to 3, 1 point, cardiac surgery, 2 points, emergency surgery, 2 points, BIS greater than 60 intraoperatively, 2 points. ARI greater than or equal to 4 predicts awareness with an OROC of 0.87. Modified Bryce score, MBS assigns 1 point for each affirmative answer: heard conversation, felt pain, felt awake. MBS greater than or equal to 2 indicates probable awareness. Management and treatment. When intraoperative awareness is suspected, BIS greater than 70, hemodynamic signs, patient movement, immediate steps include: 1. Increase hypnotic depth. Administer a propofol bolus of 0.5 mg kg superscript 1/4 over 30 seconds. If volatile anesthetic is used, increase ET-SIVO by 0.2 Mach. 2. Confirm neuromuscular blockade, check TOF. If TOF 0, give rocuronium 0.6 mg kg superscript 1/4. 3. Analgesic augmentation, give fentanyl 2 g kg superscript 1/4, or remifentanil 0.2 g kg superscript 1 min superscript 1 infusion. 4. Reevaluate BIS, target 40 to 55 within 2 minutes. 5. Document events, note time, BIS trend, hemodynamics, and interventions. Continuous monitoring of MAP, SpO2, EtCO2, and temperature is mandatory. Maintain MAP greater than or equal to 65 mm of mercury, or greater than or equal to 70 mm of mercury in patients with chronic hypertension, to avoid cerebral hypoperfusion that may confound EEG interpretation. References. 1. Kumar M. et al. Anesthetic stability of propofol, dexmedetomidine, and isoflurane by measuring bispectral index, BIS, and hemodynamic indices, a comparative study. Curious. 2022, 14, 5E24930. PMID, 357064748, https://pubmed.ncbi.nlm.nih.gov/357064748. DOI 10.7759/curious.24930. 2. Dustin Boone M. et al. Processed intraoperative burst suppression and postoperative cognitive dysfunction in a cohort of older non-cardiac surgery patients. Journal of Clinical Monitoring and Computing. 2022, 36, 51433-1440. PMID 3486256, https://pubmed.ncbi.nlm.nih.gov/3486256. DOI 10.1007/S10877-021007830. 3. Preston K. L. et al. Prevention of Accidental Awareness Under General Anesthesia, a Regional Service Evaluation. Journal of Perioperative Practice. 2024, 34, 12394-400. PMID 385899993, https://pubmed.ncbi.nlm.nih.gov/385899993. DOI 10.1177/17504589241228201. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.